is it time for TE? And it's about a 64-year-old woman with hepatic cancer. First of all, I want to show you the study which was performed 3 years ago. It's the peristernal long axis view. Again, a patient with aortic valve stenosis. Just to make it short, here are the gradients over 5 meters. She was symptomatic at the time, had an aortic valve area of something in the range of 0.7 centimeters squared. She still had good left ventricular function, so she received an aortic valve. And everything went well for the following years. And then the next time I saw her was in August, so this month. And this is her echocardiogram. And again, I just want you to focus on the aortic valve and see if you see anything abnormal here. Okay, I'll just focus in on the aortic valve. I hope you can see that very nicely. Now, this is a bioprosthetic aortic valve, a short axis view. Okay, this is the M mode across the aortic valve. She also has significant mitral annular calcification. By the way, if you compared it with the previous study, you can see that there's actually a progression of mitral valve annular calcification, but this is not really what I wanted to show you. I want to make a different point. But before I do that, I want you to judge the aortic valve and see if anything is abnormal or not. Okay. And now the gradients. 4.9 meters per second. That adds up to a maximal gradient of 94 millimeters mercury, very, very high again. Maybe not as high as in the first case, but still very high. A mean gradient of 51 millimeters mercury. And now you have to answer the following question. Okay. I can't see the polls here. 1 second. Just give me a second. While I try to fix this technical bug here with putting the poll up, just take a look at this valve again. Would you perform a TE study in this patient? Okay. If you think the diagnosis is clear anyway, why would you need a TE study? After all, who wants to have a TE study in the first place? Yes, because after all, you could get some additional information, or it could be something else. Here are the results. Okay, so generally 80% of you would perform a TE study, and I agree, because what we see here is we see fuzziness and haziness on the aortic valve, and we see something which looks very much like actually endocarditis. And you know, if you look at the images closely, the diagnosis is pretty clear. And if I tell you that the patient came in with fever and she had a very high CRP with a value of 14, then I think everything is quite clear. But now, of course, we can go on and say diagnosis is clear, she has endocarditis, we don't need to go further. But there are some issues which need further clarification. And I will now show you the TE study and show you exactly why a TE does provide so much additional information. I'll go right to the aortic valve. Now, this is the aortic valve. This is the bioprosthesis. And even though this is maybe not the best of all TE qualities, we've seen better studies, you can still appreciate that there is a lot more information. First of all, yes, the vegetation is here right on the aortic valve, on the cusp of the valve. But then you also see that there's this echo-free space, which does show a few echoes inside, and then there's motion of this part of the aorta here. Now, what this patient has is, and you'll appreciate that here in a short axis view, is that there is already an abscess formation around the aortic valve. Here's the vegetation, and let me see if I get a better short axis view somehow. Where here? Here, I think, yeah. Here you can see that there's almost beginning dehiscence of the prosthetic valve, which is here, and that there is a cavity which has formed, and that there is flow probably into this cavity because there's pulsation. We usually call this a pseudoaneurysm, right? So a pulsating structure is a pseudoaneurysm, and it usually occurs because there's partial dehiscence right here at the hinge point of the prosthetic valve. And then what happens is that we have flow into this region. You can see this very nicely here. We have flow that goes into this region and back out. And there most likely is what you can almost call a fistula between the ascending aorta and the LVOT. So there's blood flow which goes here and probably back in here and then back out again. And then there's also flow from this cavity, from the pseudoaneurysm back into the LVOT. So not only do we have endocarditis, but the additional information we have is that she also has a complication of endocarditis, namely abscess formation and also a pseudoaneurysm. So a very, very dramatic or severe finding. And this, of course, would mean that we probably need urgent surgery for this patient. I think you will all agree. The only problem in this patient is, and I'll show you this patient again from the transthoracic approach. Okay, the only problem we have is I put the transducer also to the liver, and this is what I found here. Now, this is a very obvious finding of tumor in the liver, and the patient has a hepatocellular carcinoma of the liver, and she's under chemotherapy. A big problem because now we can't even give chemotherapy. After all, you know, with fever, it's not a good thing to put her under toxic chemotherapy. But nevertheless, we're now in the phase of discussing with the surgeons if we'll do it or not. One major question will be what her lifespan is, if we can help her or not. But on the other hand, she's a young patient, so I think we will probably go on to giving the patient a new prosthetic valve and hoping that she will recover with the infection and despite her tumor she has. After all, that's her only option, because if she has a prosthetic valve endocarditis, the chance of treating her conservatively with antibiotics and medication is practically zero. Just to add some more information, the blood culture showed that she had streptococcal infection. So, okay. So this is the information we got from this patient. Now let's go back to the slides. Let me show you again some benefits of TE and endocarditis. First of all, if the diagnosis is uncertain, in this case it was not uncertain, but still, you know, you might be not so sure, then you do a TE. If you want to see complications of endocarditis, if you want to see if other valves, for example, the mitral or tricuspid valve, also have a vegetation, we've seen that. We've seen multi-vessel endocarditis in patients. Then it is also a good idea to do a TE. To follow up patients, if you would say we'll go conservatively, it's nice to have a TE study as a baseline to follow her up. It's better than following her up with a transthoracic echo. And then, especially in prosthetic valves, because in prosthetic valves, transthoracic echocardiography is inferior to TE, no question. So this is the reason we performed a TE in this patient.